Today in this class, we will discuss about the urinary bladder. The urinary bladder is a muscular reservoir of urine. It lies in anterior part of the pelvic cavity. The detrusor muscle present in the wall of the urinary bladder is arranged in whorls and spirals. It is adapted for the mass contraction rather than peristalsis. The size, shape and position of the bladder depends on the amount of urine it contains. The empty bladder is entirely pelvic in position. As it fills and expands, it extends upwards into the abdomen, reaching up to the umbilicus or even higher. The empty bladder is tetrahedral in shape, having an apex, a base, a neck, and three surfaces, that is superior, right, and left inferolateral surfaces. And there are four borders. There are two lateral and one anterior and one posterior. The apex is directed forwards and connected to the umbilicus by median umbilical ligament, which represents the obliterated embryonic urachus. The base of the bladder, or the fundus is directed backwards. The base or the fundus of the bladder is directed backwards. The full bladder is ovoid in shape, having apex directed upwards towards the umbilicus and a neck directed downwards. It is having two surfaces, an anterior and a posterior. The base of the male bladder is separated from the rectum by rectovesical pouch having coils of intestine. The lower part is related to the seminal vesicles and termination of the vas deferens. The triangular area between the two ductus deferens is separated from the rectum by rectovesical fascia of Donovius. This dissection shows that this is the urinary bladder, is the apex, here is the base, this is the anteriorly, here you can see it is pubic symphysis, and posteriorly here you can see the base of the bladder is related to the rectum, and there is a fold of peritoneum which reflects from the superior surface of the urinary bladder onto the rectum in the male, and this forms the rectovesical pouch. The lower part of the base here, you can see it is separated from the rectum by the rectovesical septum or the fascia of Donovius. Here you can see the anal canal. And this is what you can see. The bladder lies onto the prostate. Here, this is the prostate. The base of the female bladder is related to the uterine cervix and the vagina. Here in this section you can see this is the urinary bladder, and here you can see the body and the cervix of the uterus. Here you can see the base. This is related to the cervix and the anterior wall of the vagina, and the peritoneum here you can see it reflects from the superior surface onto the anterior surface of the body of the uterus, forming the vesico-uterine pouch. Anteriorly, here you can see this is the pubic symphysis pubic bone, and between the urinary bladder and the pubis bone, there is the retropubic space which is filled with the loose connective tissue and fat. The superior surface in females is covered by peritoneum, the greater part, except a small area near the posterior border, which is related to the supravaginal part of the uterine cervix. So, in the females, the peritoneum covers the greater part of the superior surface of the bladder, except a small area near the posterior border, which is related to the supravaginal part of the uterine cervix. The peritoneum from the superior surface is reflected to the isthmus of the uterus to form the vesico-uterine pouch. In males, it is completely covered by the peritoneum. The superior surface is completely covered by the peritoneum in males, and it is in contact with the sigmoid colon and coils of terminal ileum. Here you can see the superior surface of the urinary bladder. This is the fundus of the uterus. Here is the body of the uterus, and here you can say the peritoneum is reflected here from the superior surface onto the body of the uterus, forming the vesico-uterine pouch. This is what you can see is a uterine tube, and this is the broad ligament of the uterus. The inferolateral surface of the bladder is devoid of peritoneum. It is separated from each other anteriorly by anterior border and from the superior surface by lateral border. In male, each surface is related to the pubis, the puboprostatic ligaments, the retropubic fat, levator ani, and obturator internus muscle. In the females, the puboprostatic ligaments are replaced by pubovesical ligaments. The rest of the relations are the same as in the male. Here, you can, in this dissection, you can see the superolateral surface, the anterolateral surface of the urinary bladder. Now, in the male here, you can see the bladder rests on the prostate, and here anteriorly you find the puboprostatic ligaments. Here what you can see is this seminal vesicle, the left, you can see left ductus difference. This is the left ureter. The neck of the urinary bladder is the most fixed part. It lies 3 to 4 cm behind lower part of the symphysis pubis, a little above the pelvic outlet. It is pierced by internal urethral orifice. In males, the smooth muscle bundles surround the bladder neck and prostatic urethra. These muscle fibers are arranged in a distinct circular collar with their own distinct adrenergic innervation. This is pre-prostatic sphincter and it is divided of parasympathetic cholinergic nerves. It is the part of the proximal urethral sphincter mechanism. In females, the neck is related to the pelvic fascia, which surrounds the upper part of the urethra. In infants, the bladder lies at a higher level. The internal urethral orifice lies at a level of superior border of the pubic symphysis. It gradually descends to reach the adult position after puberty. In this dissection, you can see the neck of the urinary bladder, male urinary bladder, which lies on the base of the prostate. This neck is pierced by the internal urethral orifice. Here you can see the levator and eye muscle laterally, and this is the membranous part of the urethra. Posteriorly here you can see the seminal vesicles, and this is the vas difference, and here what you can see the dilatation in the vas difference, that is the ampulla. This is the ampulla of the vas difference. The interior of the urinary bladder, in an empty bladder, the greater part of the mucosa shows irregular folds due to the loose attachment of the muscular coat. Trigone. This is a small triangular area over the lower part of the base of the bladder where mucosa is smooth due to the firm attachment to the muscular coat. The apex is directed downwards and forwards, having opening of the internal urethral sphincter. The ureters open at the posterolateral angles. These openings are 2.5 cm apart in empty bladder and 5 cm apart in distended bladder. Uvula vesicae. Uvula vesicae is a slight elevation on the trigone immediately posterior to the urethral orifice. It is produced by the median lobe of the prostate. The base of the trigone is formed by interureteric res or bar of Mercier. It is produced by the continuation of the inner longitudinal muscle cord of the two ureters. The ridge extends beyond the ureteric openings as ureteric folds over the interstitial part of the ureters. The capacity of the urinary bladder. The mean capacity of the urinary bladder in male is 220 ml, varying from 120 to 320 ml. Filling of the bladder beyond 220 ml causes a desire for micturition, and bladder is usually emptied when it is filled to about 250 to 300 ml. The filling of the bladder up to 500 ml is tolerated, and beyond that it becomes painful. The referred pain of full bladder is felt in lower part of the anti-abdominal wall, perineum and penis. The root value of the nerve supplying are the sympathetic nerve, that is the T11 to L2, and parasympathetic nerves from S2 to S4 spinal nerves. In this dissection, you can see the interior of the urinary bladder. You can see the folded mucosa of the empty bladder. Here posteriorly there is a triangular area where the mucosa is firmly attached. The at the superior-lateral angles of this triangular area, you find the openings of the ureters, the right and left ureters. In the empty bladder, these openings are 2.5 centimeter. Inferiorly here, at the apex, you find the opening of internal urethral sphincter. Here you can see the ureter going posteriorly on the base of the urinary bladder. This is the vas deferens, and here what you can see is the external iliac vessels. The cystoscopy is a procedure by which we can examine the interior of the urinary bladder. A cystoscope is passed through the urethra and we can see the interior of the urinary bladder and find any disease. This is the image of the mucosa of the urinary bladder seen on cystoscopy. You can see this folded mucosa. This urinary bladder can be visualized ultrasonographically and the size of the bladder can be measured. This is the X-ray of the intravenous pylography, and here in the intravenous pylography you can visualize the urinary bladder in the pelvis. This is what you can see is the ureters, is the renal pelvis, kidney you can see. This is the ascending cystography. You can put a catheter through the urethra and put a dye in the urinary bladder and take an X-ray, and you can find any anomaly in the urinary bladder. The blood supply. The arterial supply is by superior and inferior vesical arteries, which are the branches of anterior trunk of the internal iliac artery. The additional supply of the bladder is received from obturator artery and inferior gluteal arteries. In females, the uterine and vaginal arteries replace the inferior gluteal artery. The venous drainage. There is a vesical venous plexus present on the inferior lateral surface. Veins from this plexus pass in the posterior vesical ligament and drain into the internal iliac vein. The lymphatic drainage. The lymphatics mainly drain into the external iliac group of lymph nodes, but a few lymphatics they pass in the internal iliac lymph nodes and also in the lateral aortic lymph nodes. Here you can see in this dissection the obturator artery giving additional supply to the urinary bladder. And here you can see the superior vesical artery, which is a branch of the anterior division of the internal iliac artery. This is the internal iliac artery, dividing into anterior and the posterior division. So, in the females, this uterine artery also supplies to the urinary bladder. The nerve supply. The There is a vesical plexus of nerves which is derived from the inferior hypogastric plexus. It contains both sympathetic and parasympathetic fibers. Each of these fibers have sensory and motor in nature. The parasympathetic efferents or the motor fibers are derived from nervi irrigans, root value S2 to S4. They are motor to detrusor muscle. It does not supply the pre-prosthetic sphincter. If these nervi irrigants are destroyed, then the normal micturition is not possible. The sympathetic efferents of the motor, they are derived from T11 to L2. They are inhibitory to the detrusor muscle and they are motor to the pre-prosthetic sphincter mechanism. The somatic pudendal nerve, root value S2 to S4, supplies the sphincter urethrae. It is voluntary, present in the wall of the urethra. The pudendal nerve has got a voluntary control on micturition. The sensory nerves, which carry the pain sensations caused by the distension or spasm of the urinary bladder, are carried mainly by parasympathetic and partly by the sympathetic nerves. In the spinal cord, the pain arising in the bladder is carried by lateral spinothalamic tract, and awareness of the bladder distension is in the posterior columns. So this fact is used to relieve the pain, intractable pain of carcinoma of the urinary bladder. We do lateral cordotomy, and the bilateral anterolateral cordotomy therefore selectively abolishes pain without affecting the awareness of bladder distension and desire to micturate. So this is used to treat the intractable pain of the carcinoma of the urinary bladder. Here you can see the pelvic plexus of the nerves. This is giving, this is derived from here from the inferior hypogastric plexus and it supplies to the urinary bladder. Here you can see the similar vesicles, posterior is the rectum. Here you can see the vas deferens. This is the obturator nerve, you can see. This is the ureter. This is the internal iliac artery dividing the anterior and the posterior division. The micturition. When the bladder fills without much rise in intravesical pressure due to the adjustment of bladder tube. When the quantity of the urine increases more than 220 ml, the intravesical pressure rises. This stimulates sensory nerves and produces desire to micturate. If this is neglected, the rhythmic contraction of the detrusor muscle starts, which becomes more and more powerful as the quantity of the urine increases. This gives a feeling of fullness of bladder, which later on becomes painful. The voluntary holding of the urine is due to the contraction of the sphincter, urethra, and the perineal muscles with coincident inhibition of the detrusor muscle. The successive events of micturition. First, there is relaxation of the perineal muscles, except the distal urethral sphincter, and contraction of the abdominal muscles. It is followed by firm contraction of the detrusor muscle and relaxation of the proximal urethral sphincter mechanism. So, this relaxation of the proximal sphincter mechanism, and lastly, there is distal urethral mechanism relaxes and the flow of the urine begins. The bladder is emptied by contraction of the detrusor muscle, and this is assisted by contraction of the abdominal muscle. When urination is complete, the detrusor muscle relaxes, the proximal sphincter mechanism contracts, and finally, distal urethral sphincter mechanism contracts. In males, the last drops of the urine are expelled from the bulbar portion of the urethra by contraction of the bulbospongiosus. This flow of the urine in maturation can be monitored by urinary flowmetry. Patient is asked to maturate in a bowl, and the recording is done. So this is a non-invasive investigation, the valuable particularly when combined with an ultrasound measurement of post-maturation residual urine volume. It has a base collecting system here. It is a spinning disc, and the flow of the urine into this disc tends to slow its speed of rotation, which is a servomotor force constant. The urine flow is derived from the measurement of the power necessary to maintain rotation speed, and the machine usually produces a graphic printout together with the analysis for the time taken to reach the maximum flow. This maximum and average flow rates are, and the voided value, this is all recorded on the graph paper, and this is of use in the diagnosis of the enlargement of the prostate. The simple ultrasound machines are now available that require little operator training and make it easy to determine whether the post-maturation residual urine is visible or in excess. If the urine post-maturation urine residual is more than 100 ml, then this is pathological and it needs treatment. This is a diagram of the post-maturing cystogram. We can see the maturating maturation, and we can record it. This is of importance for the diagnosis of the various diseases of the bladder, having UTI, guiding difficulties, psychourethral reflex, etc. In the case of trauma, there is a suspected anomaly of the neck and urethra. In adults, it is of use in the functional disorders of the bladder. We can by this we can diagnose the vesicovaginal fistula, which usually this is congenital anomaly uh, in which the urinary bladder communicates posteriorly with the vagina. Here, this is the we can diagnose this communication between the bladder and the vagina. Then sometimes the urethus may be patent, and this may also be diagnosed by this maturing testosterone development. The most of the bladder is developed from the cranial largest part of the vesico-urethral canal connected with the allantois and is endodermal in origin. The lumen of the allantois gets obliterated to form urachus, connecting the apex of the bladder to the umbilicus. This forms a median umbilical ligament. The tribune of the bladder is formed by absorption of the mesonephric ducts and is mesodermal in origin. With the time, the mesodermal lining is replaced by endodermal epithelium. So the epithelium is entirely endodermal while muscles are of splanchnic origin, that is mesodermal origin. So that is all about the urinary bladder and its applied anatomy.